Welcome back to the next prescription. It's Agent RX, and welcome to episode 9. Today, we will be continuing with our interview series as I am joined by Dr. Dhaval Parikh.
Hello, how you doing?
Good, how are you?
Good. Thanks for having me on.
Yes, I'm so glad you're here. So, would you like to tell us a little bit about what you do, like your profession?
Sure. I am a radiation oncologist. That means I treat cancer patients using high energy x-rays. So not like a typical radiologist where they're using x-rays to find out what's going on in your body and trying to analyze it and do that. I actually use those x-rays to treat cancer and kill off cancer cells.
Mm-hmm. And what piqued your interest in this field of medicine?
So I actually got interested in oncology back when I was in high school. I was doing some volunteer work at a hospital, and they assigned me to the oncology ward, and I had no idea what oncology was. But you know, all these patients, they had cancer, they were getting chemotherapy or other treatments, and one thing I realized is that they're all really scared and they're all nervous and everything about what's going on. And, I was just a high school kid, but I could talk to them a little bit and that would cheer them up and make a little bit of a connection. And I realized this is something I would like to do. These are the kind of people that I would like to be helping. And that got me interested in oncology. And I was planning on being a cancer doctor all through med school. Towards the end of medical school, someone pointed out, that instead of going into medical oncology, which is where you treat patients with chemotherapy, I could treat them with radiation. And I liked physics, so I was like, well, that's doable, and it looked cool, so I got into that, and I very much enjoyed my career. You know, it's very different. One of the things that's interesting about radiation oncology is that back when I was in medical school, through 4 years of medical school, we spent 2 hours learning about radiation oncology.
Oh, wow.
Okay, yeah, and that's probably twice as much as anyone else did. So it's we had 2 lectures on it. Now the field has changed a lot. There's been a lot of advances, and it's become very popular. So it is now a more competitive specialty. But that's because of all the advances that have occurred in there, and it's fulfilling. It's something unique. But now I'm sure they teach more than 2 hours worth.
Yeah. Was it a new and emerging field when you first started learning about it, or had it been there?
No. I mean, they've used X-rays to treat cancer for many years. But the problem is that we just didn't even have the math to be able to do a lot of these calculations to figure out how it was working. So when you go back to the first cyclotrons that were used to treat patients, you would basically, you knew they were giving off X-rays. You could sort of not guess, they could measure about how much was giving off, but you didn't know what it was doing to the body necessarily. But you knew that certain doses were enough to kill cancer and how many treatments you would need. I remember reading in one of the old textbooks that they had what they called an erythema dose. You basically treated patients until their skin got red. And that's how you could do it. I mean, you can do a lot better than that now.
Yeah.
But I'll tell you, and this is something that this generation is a little spoiled over, how much computers have changed our lives. Back when I was even in medical school, the calculations we would do to figure out how the X-rays traveled through the body, we couldn't do 3-dimensional calculations. So you sort of assume that the body was shaped like a cylinder. You would do a contour of, let's say, the head or the breast tissue if you're treating breast cancer, and you just sort of assume you extrapolate it superiorly and inferiorly to cover that area, because the math to do things in 3 dimensions it was way too complex. We didn't have computers that were able to do those numbers there. When I got in medical school, and then when I was doing residency, they finally started being able to do 3D algorithms, and the first 3D calculations that were done, it would take about 2.5 hours to run a plan, okay, which you would look at, and then if you wanted to change it, you'd make some changes, then you have to wait another 2.5 hours to get all the calculations done and everything. Now those calculations are done in about a minute at most, probably closer to 20 seconds, So yeah, and they're much more accurate as well. So a lot has changed. We can do things now that we could never do before.
You said a word, I think it was cytochrome. Could you please explain what that word?
Cyclotron, yeah. So that was one of the early radiation units, and I think it was a cyclotron. I'm not sure. It's basically, they all fall under the categories of what's called a linear accelerator. Okay, and a linear accelerator basically generates very high energy X-rays. Okay, and I believe like a regular chest X-ray that you would get, the energy of those X-rays is about a little under 100 kilovolts. Okay. We are in the megavoltage range. We use traditionally, about between 6 and 10, sometimes 15 megavolt beams. So those are, compared to a 100 millivolt, kilovolt thing. So we're about 100 times more, so they pack a lot more punch. These X-rays, as they travel through the body, will cause disturbances within the cells, okay, ionizations, which damage the cells. The X-rays don't know the difference between a good cell or a bad cell, and it does damage to both, okay, whether they're cancerous or not. But we give a small amount of radiation on a daily basis. Normal healthy cells can repair that radiation damage very, very efficiently. Okay. In fact, most cells can get about 95% of their repair work done within the first 4 to 6 hours. Okay, and we're giving a day between treatments, so by that time, all the cells have the normal cells have recovered. Meanwhile, the cancer cells, on the other hand, they're locked in the growth phase. That's what cancer is. Cancer is cells that have got stuck in the growth phase. They keep replicating. They create a mass that just keeps growing and growing and replicating that way. Well, because they're in the growth phase, they don't do any maintenance on themselves. Okay, so if you remember from biology, where you have the cell cycle, the G phase and the S phase, yeah. So the ones that are in the S phase, the synthesis phase, they get stuck there, and that's where the damage that's been done by the X-rays, it builds up. So each day they get injured, they don't repair themselves. Next day they get injured some more. Next day some more and some more. And over the course of these treatments, we do more and more damage to the cancer cells until we finally kill them off. While meanwhile, the normal cells just keep recovering. So that's how we can be selective about that. So it's a little simplified, but that's the basics.
So what is, if I were to go through radiation therapy, what would like the day of, or how would my schedule look like? What would the process be like?
So the first meeting is what we call the consultation, and that works, same thing with anyone going through surgery or any other kind of treatment. You meet with a doctor, that would be me, and we would go over all of your films, your pathology report, do a detailed history and physical, find out exactly what's going on with you, and then develop a treatment plan. Okay. Now, the thing is, cancer is a very multimodality specialty. So often patients are getting not just radiation, they sometimes need surgery, sometimes they need chemotherapy, immunotherapy, hormone therapy, different things. Okay. And I handle the radiation part of it. There's another doctor that would handle the chemotherapy part of it. That's the medical oncologist. And then there's the surgeon, who usually the surgeons are more site specific. So breast cancers, you have breast surgeons. Abdominal cancers, you have general surgeons, Joanne cancers, gynecologists, etc. So you work, that's one of the fun things about oncology. You get to work with all the different specialties. They're all very site specific, but you're disease specific. So, you know, and, you know, since cancer can occur everywhere, that goes on. So I'd see the patient. I'd go through all the stuff. Usually before I even see them, I've talked to their specialists and we've, you know, figured out exactly what we think the best course of action is for that patient. Otherwise, when I see them, I'll examine them and come up with what I think is the best thing. We'll talk about it, but then I'll touch base with the rest of the team. So that way we can all be on the same page and coordinate all the care. From the radiation standpoint, before we start, we have to do what's called a simulation. Okay. The day of the simulation is where I do my planning. Okay. I'll have the patient come in and we will get them in the exact position we're planning on treating them, because we need someone, you know, when we're treating you with the x-rays, we want it to go exactly where we want it to be. So we need you to be in the same exact position every day for treatment. So we have different types of immobilization devices, you know, that we have to custom make for your body. So one of the most common one is what we use, a vac fix bag. Okay. Someone made a lot of money off this idea. Basically, it's like a beanbag chair. Okay. You've all had, you know, you lay down in the beanbag chair, it's shaped around you. And then what we do is we suck out the air so that it just takes on your shape. Okay. And it's vacuum sealed. So now you get up and that still has the cradle of your body in there. So then every day when you come in for your treatments, you're just going to lie down in that cradle. So we know you'll be in the same spot.
Okay.
For other areas of the body, like the head, we actually have a mask that we make over your face to help hold your head still. It starts off as a warm piece of flat plastic, and it's got holes in it so you can breathe, and it's just over your face. It's like a mesh, and we attach it to the table. Okay, and then as it cools, it solidifies. So now we have this plastic mask that's going to keep your head very still every day for treatment. Okay, so we get you in the exact position we're planning on treating you. Okay, then we do a CT scan of your body in that position. Now, CT scan is going to recreate your body in the exact position we're treating you in 3 dimensions. Okay, so that scan gets transferred to our planning computer, which recreates your body in 3 dimensions. Okay, you get to go home, and then I work with the computer images. I go through each slice of the CT scan. I identify where the cancer is, and I also identify where the critical structures are. For example, if we're treating someone's breast cancer, we really don't want to get much radiation to their heart or lungs, so we have to shape the radiation around that. If we're treating the head and neck cancer, there's all sorts of structures we need to avoid. The voice box, the salivary glands, the spinal cord, esophagus, you know, and if it's higher up, we have to avoid the eyes, things like that. You know, so every part of the body has structures that you're trying to avoid, but you have to make sure you get all the cancer cells. Okay. So I identify where I need to treat. I set the doses I want to go to the different areas, as well as the dose limits that I want to go to the critical structures. I then work with our physicist and a dosimetrist. The dosimetrist is the one who will actually come up with, you know, she runs the computer and we'll try different plans until we get one that we like, you know. And that can take like 3 or 4 days to get a really good plan done, you know. And once we get all the planning done, then we're ready to actually start the treatment. So you've come in for the consultation, come back a couple of days later for the simulation, and then we work on it. And then once we're ready to start the treatments, then you'll come in for the treatments. Now, once your treatments start, you're typically coming in every day, Monday through Friday, 5 days a week. Okay, and it depends on the type of cancer that's being treated. Sometimes the course of treatment is just 4 or 5 days, you know, done every other day. That's for some types of lung cancer when they're caught really early. There are other treatments that are going to take a lot longer. You know, that can be once a day, you know, 5 days a week for 6 or 7 weeks, sometimes 8 or 9 weeks. Okay, so now each treatment only takes about 15 minutes, not very long. Okay, you come in, lie down on the table, we get you that whatever mobilization device we had. The machine turns around and gives you x-rays. You don't feel a thing. Okay, and after the treatment's done, we get you off the table, you get dressed and go home. Do it again the next day. Okay. And that's basically what is involved with the actual delivery of the treatment.
So by the sounds of it, so you do radiation therapy on any part of the body. Is there like a specific, if this is true, then like, if this isn't true, then which part do you specialize in? if this is true, then is there like a specific area that you find the most fascinating?
So it depends on where you're working. Okay, a lot of if you're in a large group, sometimes you'll specialize in one type of cancer. But so before, when I was part of a large group, I was doing a lot of prostate cancer, as well as a lot of breast. Prostate, breast, and lung are the three most common cancers. Number four is colon or colorectal cancers. So those are the majority of what you see. But there's also strange cancers, sarcomas, ocular melanomas I've treated, which are like cancers of the eye. A lot of GYN cancers, gynecological ones as well. And, there's different techniques for all of them. But so I did more of those other ones there. But now I'm working in a hospital pretty much as the only doctor, only radiation oncologist there. I'm still part of a group, but I'm the only one at that hospital. So I pretty much see everything.
Pretty cool.
Uh-huh.
I was also wondering if you could explain the difference between like radiation therapy or other types of like therapy or treatments for cancer, so just chemo.
Okay. So the different types of tools that we have to treat cancer, there's basically three categories, okay, and three specialties: surgery, radiation, chemotherapy, okay, or medical oncology, I should say. And those are the three specialties you'd see. So I like to think about it as if you had a fire, okay, in the kitchen, okay, one solution, if your pot's on fire, take the pot out of the house. If the pot's out of the house is safe.
Right.
Okay, the fire is outside the house. That's what the surgeon does. Gets rid of the pot. And as long as that was the only area the fire was in, you're fine. The house is safe. Let's say the fire spread beyond the pot. If that's the case, taking the pot out of the house does absolutely no good. So then surgery is really not the option. If the cancer is a little more spread, you can use a fire extinguisher. That's what radiation is. It's a local treatment. Okay, radiation just treats the area that I'm pointing the beams at and everything in that area, but it's really good for getting microscopic disease, things that you can't see. So let's say you got the pot out of the house, but there were still some embers that were flying around. Okay, maybe there were, but maybe they're not. You're not sure there. That's where the radiation can help out. We can use the fire hose or the fire extinguisher to just get rid of that air, any cells that might be left in that area, right? If the fire spread further than that, okay, or if there's a chance that the fire is spread further than that, because like I said, embers could be flying out all over the place, then you need the sprinkler system. And that's what chemotherapy is. Chemotherapy is medicine that's given through the veins, usually, sometimes orally, but it gets into the bloodstream and fights the cancer cells wherever there are in the body, okay? So that's very effective in that now you're targeting everything. But the downside is that you could potentially be causing side effects everywhere. Okay. Radiation only causes side effects in the area we're treating. And surgery only causes side effects from what it removed, So whatever is taken out is no longer part of you. You got to work without that, But, so each one there. And it's the thing to understand is that we're really not in competition with the other doctors. Certain cancers are going to be better treated with surgery. Some are the kind of cancers that surgery is not going to help out with. You need more chemotherapy and radiation, So we work with the other physicians and we, figure out what's the best treatment for each individual patient. So there's a lot of communication that goes on there.
Now, bringing back to radiation therapy specifically, I'm sure you've heard of 3D bioprinting, and if our listeners haven't, to check out episode 2 of the next podcast. But what are your thoughts of 3D bioprinting in cancer treatment, but specifically your field of radiation oncology?
So, I think the idea of 3D printing, period, was something that sounded really cool, and it actually has come a long way and has become very successful. And I will tell you, as a kid, we thought about having like a 3D printer, or 3D pen, where you could just draw something and it would turn into a solid, and that would be really neat. And it's actually happened. So that's exciting.
Yeah.
The idea of being able to 3D print something as complex as human tissue is, I think it's several orders of magnitude more complicated than we think it is. Making some simple bioprinted structures that can just maybe help support tissue, like, something that's not really metabolically active, like a cartilage or something, structurally to help out, is one thing. But to make a kidney or some other organ there, that is much more complex. And to be able to do something like that in a cancer setting is even more complicated. One example I use for when I've talked to patients and families about cancer in general is the whole mechanism of cancer. So everyone knows about DNA. Big long molecule contains the blueprint of your entire body. And that is 3 billion base pairs, right? In a single molecule of DNA. And that is your code that tells you how things are happening. If you're going to replicate it and print that in any form, okay, how accurate are you going to be?
Right.
99% accuracy means you have in 3 billion base pairs, 99% accuracy. You're doing your math right now. That means how many errors?
A lot, to say the least.
30 million.
30 million.
Okay. So 3 billion, that's 30 billion. Okay. So that means if you had a process of bioprinting that was 99% accurate, which right now, I think if you can get to 90% accuracy, that would be really cool. But if you got to 99%, you're still making 300 million errors, 30 million errors every single time.
Right.
If you get it another order of magnitude better, you're getting it to 99.9% accuracy. You're still making 3 million errors everywhere. Cancer occurs when one of these errors occur in the wrong spot. That's what cancer is. Okay. 3 billion. If each base pair was the thickness of a sheet of paper, okay, how tall would that be? 3 billion sheets of paper. Just guess.
Maybe like the height of, I'm going to say like the Empire State Building.
A little higher than the Empire State Building. Actually, a lot higher than that.
Maybe like getting us all the way like to the mesosphere.
Well, let's go to Mount Everest. How's that?
Okay.
Okay. So it's actually you would need 35 Mount Everests.
Wow.
To get sheets of paper that thick to get to that would be 3 billion sheets.
Wow.
And do you think the likelihood of doing that without errors? I mean, again, one error in the wrong spot is going to cause cancer. My point is that 3 billion is a huge number, and the fact is, if you're going to be bioprinting tissue, you could very easily end up creating cancers that you put in people. So again, the technology is developing, but even the body isn't, it's more than 99% accurate, okay, which is amazing. But even then, we're still getting lots of errors every single time a cell divides. And to make, 1 cubic centimeter of tissue, that's about 10 billion cells.
Right.
Okay. So 10 billion cells, each with 3 billion base pairs.
Billion
That's
or million?
billion with the
Okay.
B. Yeah. I think this is one of those things where it's, you know what? We've made so many advances. These are numbers that we couldn't even do 3D calculations, like I said.
Right.
Okay. That wasn't that long ago. you know? But this is something that you've got to somehow account for the fact that getting that level of accuracy is not something we've ever been able to accomplish. Okay. And there is a good chance that if you make if something error creeps in the wrong place, that's what cancer is. So you got to be careful.
Do you think it would be helpful, though, to use 3D bioprinting in terms of understanding how the cancer works or spreads?
No. No, because what we're doing with 3D bioprinting is we're creating artificial cells. We don't need to have the artificial cells. I think there's a lot of promise in DNA fingerprinting. Are you familiar with that technology?
No.
Fingerprinting and stuff. Okay, I'll tell you about that in one second. But basically, understanding the tumor and on a molecular level, as opposed to just, well, we know this type of cancer, like small cell cancer, likes to travel this way. If you could actually take a piece of that tumor and analyze it to see what characteristics it has. So DNA fingerprinting. One of the best examples of this is something called the Oncotype test. Okay. So when looking at patients who have breast cancer, okay, they wanted to figure out, let's back up a second. When we're dealing with cancers, there was, we have to determine, like I said, if you have that fire that's occurring, is this fire likely to have spread embers that could have gone elsewhere in the house, right? Or is it something that was really localized and just you can take it out and not have to worry about it? Maybe you need to do a little fire extinguisher, but do you really need to start the sprinklers? Because that's going to mess up the whole house, okay? And if you need to, yeah, you don't want to lose the house, but if you don't need to, why put someone through that? Why destroy the house there that way? So one of the trickiest things we had before is we had effective chemotherapy for breast cancer, but who needs to have it and who doesn't? Okay. Before we were just looking at, okay, if this tumor got up to a certain size, statistically it had a better chance of having spread, so you have to worry about that. If it had gone to certain lymph nodes, okay, there. But all of those models were based on things that we could see, as opposed to the actual nature of the cells. If you want to think about it in a certain way, we were thinking that if it was like a rabbit in a box, I use a lot of analogies, I'm sorry. Okay.
Analogies are helpful to understand, though.
So if you've got a rabbit in a box, okay, if it's a baby rabbit, it can't jump out of the box. But if you wait long enough, it's going to grow and it's going to get big enough that it can jump out of the box, right? And then go somewhere else. So we were thinking like all cancers are like that because that's the best model we had, that once it gets to a certain size, then there's a chance of it going elsewhere. But it turns out not all cancers are like that. Some cancers are turtles. It doesn't matter how big that turtle gets. It's not jumping out of that box, okay? But other cancers are butterflies. From day one, that box was never a barrier, okay? So if we can figure out which cells are butterflies and which ones are turtles, we can figure out whether or not they need chemotherapy. That was the paradigm, okay, that we were looking at. And that's where DNA fingerprinting comes along. So with DNA fingerprinting, there are certain things we can look at where, like, okay, if this protein is present in the tumor, then it has a 5% greater chance of having benefiting from chemotherapy. If this protein is higher, then you have a lower chance. If this one is downregulated, you can do that. So they can look at all these different things, but you can't process all of that. Right. That's where DNA fingerprinting came in. What they did is they had it was a chip analysis where they could basically look at 100 different genes in a specimen that they thought were related to the likelihood of cancer progression. And they would see how they would get upregulated or downregulated and put that into this huge mathematical model, throw it in a computer, do big data analysis on it and figure out, okay, based on that, what number do we get as far as how likely it is? And they did this in a really well-controlled way. So what they did is because they could get the DNA from old tumors from 20 years ago because the slides were still there.
Right.
So they took these samples from over 1,000 women, back 20 years ago. They ran the test. It was all anonymized, so, nothing there. But they were just looking at, and then they were able to say that, okay, these were the things that went up and down, and we know how those patients did. Okay, we know what happened 20 years later in those patients. So they figured out, okay, these are the patients that had the cancer that progressed. These are the ones where it never progressed. These are the ones that had this treatment. These are the ones that didn't have that treatment. They put all that data together and they created a predictive model. Okay, said, okay, based on our studies, if it has these patterns and these, ups and downs with all these different things, we give it a number. If it has more than 28, I think that's the number they end up going with, the chances that you'd benefit from chemotherapy. If it was less than that, you probably wouldn't benefit. Okay. And what they then did, which was also very smart, is they took another 2,000 patients from 20 years ago and they ran those tests on them. And they said, okay, based on our model, this is what would have happened. And they checked it and it was pretty good. Okay. So then they got validation. So they came up with that. It was a really well designed, and they're making, it's a oncotype tests are done on every breast cancer patient now that could potentially get chemotherapy, with a few exceptions, but and now because of that, a lot fewer women are getting chemotherapy than they would have in the past, because now we know that, hey, your cancer is not the kind that's going to benefit from this. Okay. Meanwhile, you get a couple that go the other way, where just last week I saw a patient that the medical oncologist was like, yeah, they're not going to need chemotherapy. You just go ahead. We're waiting for the test, but it's going to take another couple of days to come back. Why don't you just go ahead with the radiation? Well, came back the day after, and the score was very high, and that surprised everybody. But now the patient's going to have to get chemotherapy first. It doesn't have to, but her chance of the cancer coming back is 3 times higher if she doesn't get it. So yeah, she probably will.
You answered my next question of other technologies that seem to have a promising impact in your field. So I'll ask you one more question before we let go.
Yep.
What do you see as happening in the future of your field?
I think there have already been a lot of advances in radiation as far as our ability to target tumors. We can now shape radiation around a lot of critical structures that we could not in the past. Okay. I can now do 4-dimensional treatment planning where, for example, for lung cancer, okay, we're treating a lesion in the lung. And I told you the treatments only take about 10 minutes or so, but during that 10 minutes, the patient's getting treated, they're breathing. And when they're breathing, their lungs move. Okay. And when the lungs move, the cancer's in the lungs, the tumor moves. Okay. So before, I'd have to take into account that I'm treating an area, so big, that's where the tumor is, but I know it's going to be moving. So I've got to treat a larger area to account for that. So now I'm treating a lot more normal lung. Well, now we have 2 different technologies we can use to help out with that. One is a 4-dimensional CT scan, where we can scan the patient while they're breathing in the different phases of respiration. And I can actually create a little movie about showing how that cancer moves, what path it takes through inspiration and expiration. And I can just treat that entire path. Okay. But I don't need to treat anything beyond that path. So therefore, I'm treating a lot more normal, a lot less normal tissue. Okay. So that helps out. A better option in patients that can cooperate is we now have sensors and cameras in the treatment room that can see the contour of your body, and it can see it very precisely with an accuracy of 0.5 millimeter. So we can program it to sense when you've taken a deep breath, and it will only treat you when you've taken a deep breath. So we tell the patient, take a deep breath, hold it. They get in position, machine turns on, starts giving them radiation. As soon as they move outside of the, once they have to breathe, they just breathe. We tell them, don't worry. When you have to breathe, go ahead. And as soon as they breathe, the camera senses that the patient started breathing, turns off the machine. Okay. We tell them, take a couple of regular breaths. Now take another deep breath, hold it. As soon as they get back in position, treatment starts up again. Picks up right where it left off. So it only treats when we know the cancer is going to be right where we want it to be. Okay. So that also cuts down. So these technologies, they've come out in the last few years, and they've really helped us with radiation. I don't know how much further we're going to get with accuracy. I think the advantages in radiation are going to come along the molecular level, just like I mentioned with chemotherapy. Finding out for a specific cancer what dose we need to go to, because right now we know that generally speaking, breast cancers need this dose. Well, if there are certain breast cancers biologically that don't need that much, I can stop the treatments earlier. If there are ones that I have to go a little higher, then I can give them a few more treatments and make sure we get rid of it. That I think is where customized cancer treatment, essentially. I think that's where the future might be.
All right. Well, thank you, Dr. Parikh, for joining us on our podcast today and taking us through this magnificent journey of radiation therapy. I hope you all learned as much as I did from this episode. And until next time, this is Agent RX signing out.